Thank you, Dr. Arup, for giving me this opportunity to share my experience here in front of this August gathering. And I don't have any financial interest when CTR comes handy. So this is a case which I was doing irrigation aspiration. I use bimanual irrigation aspiration, as you can see. I have been doing this for last so many years, and I don't find it any unusual. But you can see that the capsule we have got the capsule and there is a zonal dialysis there. But we should not get panicky there itself. We should continue by the irrigation handpiece, which should be kept in place and without deviating the chamber depth. It should not get shallow at any place. Leave it there, hold it from the ledge or the anterior aspect or anterior layer of the cortex there. Be gentle, and your foot pedal control should be very good. Be very, very gentle. Once you have held the cortex, then you can push the foot pedal further, and tangentially you try to pull the cortex sheet and complete the removal of IA. You can see there is no vitreous disturbance just because our chamber depth is maintained throughout. Push the viscoelastic. Our IA should be there in the anterior chamber from the second hand and fill it further through the main wound. Then the CTR should be ready in our OR. I do a lot of subluxated cataracts, so these things are ready in my OR, and this has come handy. And you should not proceed further with the IUL with so much of zonal dialysis. Even a small amount of zonal dialysis, I don't leave like that. I always use a CTR in such cases so that later on the lens doesn't get decentered. This lens is distended and it will remain like this for long, and the IOL will remain central even in the long run. You can use multifocal IOL also even with this small amount of zonal dialysis. But not all days are forgiving for you. This is another similar case which happened to occur after almost 3 to 3.5 years when I did the previous case. So I thought I will be able to finish it in a similar way. But here things are different. I am completing my irrigation aspiration in a similar way, and this technique can be adopted with caution and care. And these two cases are quite different and quite they are useful for further management. Again, chamber shallowing, chamber depth should be maintained throughout. And a CTR is injected inside, but I have missed something. I have missed something that while doing the CTR is pushed inside the capsular bag, but here I find that I'm placed the CTR in the bag, but here I found that there is a PC rent here. I will show you again, which I have missed. This is the rent. So this was the rent this is the rent which is there and which has enlarged completely. So now the situation is there is an inferior zonal dialysis here and there is a large PC rent. So what to do? So first thing and foremost thing is to remove the CTR. So it can be pulled out. You go inside the bag with the Sinskey hook and guided by the another Sinskey hook or a Lister hook through the main wound, you can pull it out so that it should not be a problem if at all anything goes wrong to a VR surgeon. It should not fall behind. Then I have completed because there is no capsular support left and we cannot place the lens in the sulcus because of large area of zonal dialysis. So I am now completing this case by doing a scleral fixated IOL in a way as we all must be knowing. So this is beyond the scope of this course. So, but still I make two tunnels 180 degree apart on each side, 1.5 millimeter away from the limbus, and the proline suture is traversed from one side to other. The suture is pulled out. The two ends are tied to the specially designed IOL, and I complete it. Lens is pushed, and the whole capsule is now removed. I don't leave that capsule inside because that can fibrose, and lens can lead to arteritis and other things with the lens itself. Now, the important thing is that before tightening the two ends, our main wound should be closed so that the astigmatism is minimized and anterior vitrectomy is done to remove the vitreous around the lens. So this is how we have managed, and the two situations. So CTR is helpful at places, and we should be very, very careful, and most of the times it has been reported the PC rent and gets during the irrigation aspiration. Another case, a small case, sir. If we are running short, then we will not stop here. Thank you.